Hello, welcome to this mini-series from the MDTea Podcast team, covering some of the more common issues encountered when working with older adults. Each session is structured around a clinical question, and our aim is to help you to approach the issue like a geriatrician, and each one is only 10 minutes long. I'm Jo Preston, I'm a consultant geriatrician in South West London, and joining me remotely I have...
I'm Alice O'Connor, and I'm a teaching fellow in East Surrey.
I'm Ian Wilkinson, I'm a consultant geriatrician down in East Surrey as well.
And this session is going to be all about atrial fibrillation, which is the most common tachyarrhythmia that we see in older adults.
So, Mrs. Hart is supposed to be going home today, but now she's in AF, and I don't know how to treat it.
So this is a relatively common, classic pre-discharge stumbling block, and there are a number of treatment options, and they can sometimes seem a little bit overwhelming as to quite where you're meant to focus and what you're meant to focus on. But there are 5 things that you can easily find out that are going to help you make a decision about what to do.
So first things first, you want to make sure this is definitely AF. If you're not entirely sure, it might be worth running through the ECG systematically, which we're going to talk you through in the next slide. Secondly, does this person have AF normally? Are they known to have AF? If you're not sure, then the medication list might be able to give you some clues. If not, then you might want to contact their GP surgery and see if they can give you any help. If the atrial fibrillation is known, then what is it that's changed that you might be worried about now that needs a decision about it? Which brings us to the third and fourth things.
So number 3 is, what's the ventricular rate, and has it changed acutely? Is the patient hemodynamically stable? If they're not, you might need to think about putting out a MET call or a peri-arrest. And number 4 is quite important. Are they symptomatic? Symptoms with AF can include palpitations, shortness of breath, dizziness, or chest pain. The timing of symptom onset can sometimes give you a clue as to the duration of AF if it's not otherwise clear. And symptoms can also have implications for management further down the line, such as whether or not to attempt a DC cardioversion.
And then the 5th thing, finally, is what drugs are they taking? Drugs can sometimes give you a clue as to whether or not this is a previous diagnosis of AF that you've just found or something new. So, for example, if someone's taking digoxin and an oral anticoagulant, it's probably old. Look to see if they've missed any of their usual drugs, especially those that might control the rate or the rhythm. Some drugs that are prescribed acutely may be exacerbating the problem. For example, if you've needed to give someone back-to-back salbutamol nebulizers, that could cause tachycardia and might be exacerbating things.
So this ECG is taken from lifeinthefastlane.com. They've got loads of other ECG examples there if you want to check it out, and lots of in-depth information about the pathophysiology of AF, which we're not going to concentrate on here. So what I really want you to feel a bit more comfortable with is that this is AF by the end of looking at this. So first thing you can notice about this ECG is that the pattern of the QRS complexes is irregularly irregular. The ventricular rate is around 100 beats per minute. And we can see that there are no convincing P waves seen before each of the QRS complexes. And certainly, even if you think you can see one, they definitely don't occur in a pattern to tell you this is a convincing regular atrial start to the QRS complex.
You might also notice some coarse flutter waves here in V1 and V2, which won't necessarily be present and don't necessarily mean this is flutter rather than fibrillation, but that's something that you might see. There's also some T-wave inversion in the inferior leads here, 2, 3 and AVF. This could be old or new, but it suggests some ischemic process, such as a previous MI or a new non-STEMI, or perhaps just rate-related ischemia.
Now, you may pick up AF just when taking someone's pulse. So if you feel that someone's pulse is irregular and it's not been documented before, it could be significant. Don't ignore it. Don't leave it at that. Get someone else to check.
So one way of approaching the examination of someone with atrial fibrillation is to look at their fluid status, especially if the ventricular rate is high. If someone's fluid overloaded, that might be because they've been in atrial fibrillation for quite a long time, which has led to impaired left ventricular function. Signs of fluid overload would be the usual things that you would see usually, so things like peripheral edema, raised JVP, shortness of breath or wheeze, depending on how acute this has become. In patients with who are underfilled, that might provoke AF in the same way that it would provoke a sinus tachycardia. This might be because this person is dry, so the rate is being driven by their dryness rather than the AF itself being out of control. So again, you'd be seeing somebody who has a dry mouth, slow capillary refill, might have reduced urine output or a postural drop in their blood pressure. If people have got a very slow ventricular rate, you want to check if they've got a pacemaker, is that working? Because some people might have pacemakers for their atrial fibrillation as well. So you want to see if there's a reason that they might be tachycardic anyway, or is this primarily an AF related rate problem? And then how is the body functioning? How's the heart functioning with that high heart rate as well?
The next thing to think about is what I've called invaders here, so things that shouldn't be there. And I've included pathogens and clots in this category. So a pulmonary embolism may cause acute onset AF by causing atrial distension due to pulmonary hypertension. Ask people about chest pain and breathlessness and look for signs of DVT. PE is worth considering as a diagnosis in anyone who's got low SATs and a clear chest. Infection can also trigger AF, even in people who may not be septic. And remember to look for the more hidden sources of infection like pressure sores and swollen joints. And finally, is there anything poisoning them? Basically, have they got too much or too little of something in their body? Aside from checking their bloods, you might, when you're examining them, pick up on signs of thyrotoxicosis, so things like tremor, exertional breathlessness, edema, hypertension, or alcohol withdrawal. So again, you might see tremors, sweating, they may be hallucinating and be very anxious.
You'll want to get a set of blood tests in any patient who's got new onset atrial fibrillation. And the basic things you're going to request are some urea and electrolytes, a thyroid function, magnesium and the calcium. And then you want to consider checking a troponin if the ECG shows any of those new ischemic changes or if the history is in keeping with an acute coronary syndrome. If you suspect a PE, you may also want to do a D-dimer, depending on your Wells score, and perhaps a troponin there as well.
So things like chest x-ray really depends on what you're looking for. So if you think there's something that's related that has triggered the atrial fibrillation you're looking for, or anything else that might be affecting the heart that you might see in the lung fields. Echo is another common investigation that is requested, but it quite often, well, most of the time, doesn't need to be done as an inpatient, and particularly won't be very useful if the person's ventricular rate is quite fast. So you want to try and slow that down and do it in a more normal phase as possible to be able to get a more detailed assessment. They can be quite useful in guiding long-term management, especially if there is coexisting heart failure or if there's a valvular abnormality. So it's really useful to do at some point, but usually doesn't need to be done acutely. 24-hour ECGs are again something we see ordered quite often, but don't really add much to the management of atrial fibrillation, because if you've seen it, then you've seen it, you've got the diagnosis. They can sometimes be useful if people are quite symptomatic with their atrial fibrillation, with breathlessness or palpitations, to work out what their rate control is and if that might be contributing to symptoms. That's really the only time that a 24-hour tape is usually helpful in this situation.
So the management of AF can be divided roughly into rate control, anticoagulation, and rhythm control. Rhythm control is a bit beyond the scope of this session and not something that you'd be expected to start or make decisions about without senior or specialist input. But with rate control, you'd initially be aiming to get the heart rate below 110 BPM. And beta blockers are a good place to start with this. So bisoprolol is well tolerated by most patients at low doses, and you've got a lot of leeway to increase the dose in small increments, up to 10 milligrams per day if they need it. Calcium channel blockers such as verapamil and diltiazem can be better for patients with COPD or asthma who can't have beta blockers. And digoxin tends to be preferred in decompensated heart failure, but is generally less effective than beta blockers or calcium channel blockers.
The reason that we anticoagulate people with atrial fibrillation is to reduce the risk of an embolic stroke. Strokes that are associated with AF have a greater morbidity, a greater mortality, and lead to a greater disability. And this is to do with the tendency for atrial clots to break off and be quite large and block the entire middle cerebral artery, causing a large volume infarct. You can calculate the stroke risk using the HAS-BLED score. There's a number of websites and apps that will tell you what the score is, and from that you can work out whether or not anticoagulation is recommended. But with anticoagulation also comes a risk of bleeding, and you can do a HAS-BLED score to calculate someone's bleeding risk and then highlight possible modifications that can reduce that risk. It's not designed to be used in conjunction with the HAS-BLED score per se, but there are a couple of articles that have got nice tables of the relevant and relative risks for you to balance things up with your patients.
So thinking about wanting to thin someone's blood, there are two main types of medications we use to do that. So antiplatelets are one group of medications. They really don't have a role in reducing stroke risk in atrial fibrillation. And ideally those should be stopped when you're starting full anticoagulation, unless there's a really specific indication for that. And usually those would be related to a cardiac procedure or perhaps a recent stroke. It'd be worth checking with the cardiac or stroke teams if they've got some of that in their recent history on antiplatelet, just to make sure, because there are certain indications where you would, but the majority of the time you only need to do an anticoagulation or antiplatelets. So first line anticoagulation these days is usually a DOAC like rivaroxaban or apixaban. The drug of choice usually varies between trusts depending on what your local policy is, so it's worth checking what your local guidelines are. Before starting someone on a DOAC, you would usually check their renal function, and you want to calculate their creatinine clearance rather than use their EGFR, particularly because people might tend to have lower weights when they're older as well. Some people are still on warfarin for atrial fibrillation. If they are, it's worth looking at their INR over the last few months and seeing whether they've had quite good control with that. If they haven't, then it might be worth talking to them about changing to rivaroxaban. If they're not on warfarin for a specific indication, like a metallic valve, then it might be worth having that conversation about switching to something else. Finally, something that people are really often worried about is anticoagulation in the context of falls, because they're worried that they'll injure themselves and cause a big problem. Now, the evidence out there is not brilliant, but there is quite a lot of evidence, and pulled together in a meta-analysis show that you need to be falling over a lot. So basically every day before your risk of anticoagulation and causing a bleed outweighs the benefits that you would achieve from reducing your stroke risk. So it's not a reason to stop someone from going on a DOAC, and actually we would recommend it by default usually.
So in the notes below the video, we've included links to the various resources we've mentioned, such as the HAS-BLED and the HAS-BLED scores. And we've also done a full-length podcast episode on atrial fibrillation, which you can find on our website, www.thehearingaidpodcasts.org.uk. And it's Series 6, Episode 6.
The MDTea Podcast and learning resources are free to use and cover a wide range of topics concerning older people. We go from diabetes to depression. You can also check out the rest of this mini-series for some more bite-sized learning. And we really hope this episode of Help has been a help. Bye-bye.
Bye.